For this chapter, we're going to look at the spinal cord, spinal nerves, and the somatic reflexes. The spinal cord and spinal nerves, they mediate reactions to the environmental changes. So any type of changes that we have coming in from the external environment as well as internally, these nerves are going to mediate and determine what response that they're going to have. So they're going to be considered to be that information highway connecting the brain with the remaining parts of the body. So in this chapter, we're going to study the spinal cord and the spinal nerves in detail, along with a few reflexes that deal with the nerves. So the spinal cord has 4 main functions. It's conduction, neural integration, locomotion, and reflexes. So let's take a look at the first one. For conduction, the spinal cord contains bundles of nerve fibers that conduct information up and down the cord. So they're going to connect at different levels of the trunk with each other and, of course, with the brain. The second function, neural integration, we have pools of spinal neurons that receive input from multiple sources that integrate the information, and then they're going to execute the appropriate output. Third function, locomotion. Motor neurons in the brain initiate walking, but continued walking is coordinated by groups of neurons called central pattern coordinators in the cord. Lastly, reflexes. That deals with it's an involuntary stereotyped response to stimuli involving the brain, spinal cord, and peripheral nerves. Now let's take a closer look at the spinal cord. Now the spinal cord has a cylinder shape. It's long and it's thin. It's full of connective tissue, and it arises from the brain stem at the foramen magnum of the skull. It then passes through the vertebral canal as far as the inferior margin of the first lumbar vertebrae, or slightly beyond. Now, early in fetal development, the spinal cord extends the whole length of the vertebral column. The vertebral column grows faster than the spinal cord. So by birth, the spinal cord extends only to L3. The cord gives rise to 31 pairs of spinal nerves. The first pair passes between the skull and vertebral C1, and the rest pass through the intervertebral foramina. Although the cord is not visibly segmented, the part supplied by each pair of spinal nerves is called a segment. Now the cord is going to exhibit anterior medial fissure anteriorly and the posterior medial sulcus posteriorly, which we'll take a little look at that a little bit later. Now the cord is divided into sections. It's divided into the cervical, thoracic, lumbar, and the sacral regions, which are named for the level of the vertebral column from which the spinal nerves will emerge, not the vertebrae that contain the cord. In the inferior cervical region, the cervical enlargement of the cord gives rise to nerves of the upper limbs. Now, in the lumbosacral region, the lumbar enlargement gives rise to nerves to the pelvic region and the lower limbs. Inferior to the lumbar region, which is lumbar enlargement, which is below here, the cord tapers to a point called the medullary cone, or the conus medullaris. Now the lumbar enlargement and the medullary cone give rise to a bundle of nerve roots called the coda equina that occupy the vertebral canal from L2 to S5. Here's a little closer look. We see actually how these bundles of nerves look like. And then we have the cone, the medullary cone in this particular region. Okay. Now let's take a look at the meninges. The meninges, the spinal cord and the brain are enclosed in three fibrous connective tissue membranes, and they're called the meninges. There are three layers. From superficial to deep, we have the dura mater, the arachnoid matter, and the pia mater. Here in this particular diagram, you see it here, the dura mater, the arachnoid matter, and the pia mater, which you don't really see. It's very translucent. So let's turn to this slide and you'll see a cross-section of the spinal cord as well as the vertebrae, how these layers will look. Now the dura mater, which is right here, it forms a loose fitting sleeve called the dural sleeve around the spinal cord. Now the space between the sheath and the vertebral bones is called the epidural space, and it's occupied by blood vessels, adipose tissue, and loose connective tissue. Now anesthetics are sometimes introduced to this space to block pain signals. Now second type of meninges, or the second meninge, the arachnoid matter. That consists of simple squamous epithelium adherent to the inside of the dura and a loose mesh of fibers spanning the gap between the arachnoid membrane and the pia mater. Now the space between the arachnoid matter and the pia mater is called the subarachnoid space, and that's the space that's filled with cerebrospinal fluid. The pia mater is very delicate, and it's a translucent type of membrane that fits that closely follows the contours of the spinal cord. So that's it here, going all the way around. That's our pia mater. Now the pia mater continues beyond the medullary cone as a fibrous strand within the lumbar cistern. Now at regular intervals, extensions of the pia, called denticulate ligaments, extend through the arachnoid to the dura, helping to anchor and to stabilize it. Now spina bifida, we've heard of spina bifida before. It's a congenital disease, defect in which one or more vertebrae, they fail to form a complete vertebral arch for enclosure of the spinal cord. So the spinal cord is not completely closed. You're going to have part of the spinal cord being exposed. Now you have 1 out of 1,000 babies are affected by this defect. And the most common region that you'll see it in will be the lumbosacral region. Now what causes it? Well, one of the reasons that some babies will be affected by spina bifida will be a lack of folic acid that the pregnant mother does not consume. That's why a lot of doctors would have, a lot of OBGYNs would tell or prescribe or have the pregnant woman take folic acid just to ensure the baby, to reduce the risk of the baby or the infant developing spina bifida. But of course, supplementation must be taken 3 months before conception. So in order for that to happen, we have to start consuming or consume foods, or healthy foods, very balanced foods that will have the proper vitamins and nutrition that our body needs, minerals and vitamins that our body needs. Alright, so here we're looking at the gray matter and the white matter. So here we have the gray matter in here, and the white matter is what is going to be surrounding this gray matter. Now the gray matter has a relatively dull color because it contains very little myelin. It consists of somas, dendrites, and proximal parts of the axons and of the neurons. Now the white matter has a great pearly white appearance due to the abundance of myelin and consists of bundles of axons called tracts. And the white matter, it carries signals from one part of the CNS to the other. But the gray matter, that's the part that does all that processing and, of course, synaptic integration. So the gray matter makes up the central core of the spinal cord, which looks like a butterfly or H-shaped in cross sections. Now the core consists of two posterior horns and two thick anterior horns. So right here, this would be our posterior horn, one on this side and one on this side. So this is our right side, and this is our left side, because this is the anterior and that's the posterior. So this is the horns, posterior horns. It also has a lateral horn and an anterior horn. Now the anterior horn is a lot thicker than the posterior horn. Now what connects these two, the left and the right side, is the gray commissure. Right here, this area right here. Now in the middle of the gray commissure is called the central canal, which looks like this little hole, which in some places in adults it remains open and is lined with epidermal cells and filled with CSF, the cerebrospinal fluid. Now the lateral horn is visible from thoracic 2 through lumbar 1, and it contains neurons of the sympathetic nervous system. Also, it's the major control center in the autonomic nervous system. Now the white matter of the spinal cord, it surrounds the gray matter all around here. Now it consists of bundles of axons that course up and down the cord, arranged in three pairs called columns. Now these columns, we have a posterior, we have a lateral, and we have an anterior. So here is the posterior column, here are our lateral columns, and here is our anterior column. Oops, let me go back. Now the three columns, like I just said, are posterior, anterior, and lateral. And each of them consists of subdivisions. And those subdivisions are called tracts. So here are our spinal tracts. The spinal tracts consist of ascending and descending tracts. The ascending tracts are going to carry sensory information up the cord, and descending tracts are going to conduct motor impulses down the cord, down the spinal cord. Now all nerve fibers in a given tract have a similar origin, destination, and function. Now many of these fibers have their own origin in a region called the brainstem, a vertical stalk that supports the large cerebellum and the two even larger cerebral hemispheres. Some of these tracts undergo decussation, meaning that they cross over from one side of the body to the other. Now, a stroke that damages motor centers of the right side of the brain can cause paralysis of the left limbs, and vice versa. Now, when the origin and the destination of a tract are on opposite sides of the body, they are said to be contralateral. And when tracts do not decussate, that means that they don't cross over, its fibers are said to be ipsilateral. Now in the ascending tracts, sensory signals, they typically travel across three neurons from origin in receptors to destination in sensory areas of the brain. We have the first order, second order, and our third order. A first order neuron, it detects stimulus and transmits signals to the spinal cord. So those are the first neurons. Those first neurons are the ones that you're going to have, just say from the extremities or from a particular organ, straight to the spinal cord. So say this is the stimulus here, and this would be the spinal cord. This would be your first neuron. The second neuron, that continues as far as the thalamus, which is a gateway at the upper end of the brain stem. So it will be from the synapse here until this is the spinal cord. It will go from the spinal cord all the way up to the brain and right to the thalamus. The third order neurons, they're going to carry the signals the rest of the way to the cerebral cortex. So that's from the thalamus up to the cerebral cortex, where in different regions of the cortex it responds to different stimuli, whether it's heat, temperature, pain. It will go in those various directions, different parts of the cerebrum. Alright, so let's take a look at some of the ascending tracts. Now there are 5 major ascending tracts. So forgive me with my pronunciations again. The first one is gracile fasciculus. Second is cunate fasciculus. Then we have the spinal thalamic tract, the spino-reticular tract, and we have 2 spino-cerebral tracts. So the first one here is a gracile fasciculus. It carries signals from the mid-thoracic and upper parts of the body. And the lower parts of the body. So we're looking at the lower limbs and mid-thoracic, so right around your torso area. Now, let me see, it composes the entire posterior column below T6, and it is joined to T6 by the cunate fasciculus. So at a particular region, these two are going to work together to send the information upwards. Now it consists of a first order nerve fiber that travels ipsilaterally. So that means it just travels up on one side. Here's our fourth order, and it's going to travel up just one side. That's our ipsilaterally, and then terminate at the gracile nucleus, which is right here, into the medulla oblongata. That's going to go up. Now its fibers carry signals for vibration, visceral pain, deep and discriminative touch, and proprioception from the lower limbs. Our second one is our cunate fasciculus, and that joins the gracile fasciculus at T6. Remember, at T6, and it occupies the lateral portion of the posterior column. So here's the lateral side, and that's the medial side. So here's the lateral side of the posterior column. So don't forget, this is the entire posterior column. We have our lateral column and we have an anterior column. But just looking at the posterior column, we have a medial, which means close to the middle, and we have a lateral. So the cunate fasciculus is going to deal with the lateral aspect of the posterior column, and the cunate would deal with the medial aspect of the posterior column. Now, with the cunate fasciculus, it carries the same type of sensory signals originated from the upper limb and the chest. So those are our arms, our fingers, and our chest area. Now, its fibers end in the cunate nucleus, which is over here, on the ipsilateral side of the medulla oblongata. Now, in the medulla, the second order fibers of the gracile and the cunate systems, they decussate which is, what's that mean? That means they're going to cross over, decussate, D-E-C-U-S-S-A-T-E. And they form the medial lemniscus, right in here. Now the third order fibers, they're going to run from the thalamus to the cerebral cortex and have lateral, a contralateral effect. So let's look at the third ascending tract, the spinal thalamic tract. The spinal thalamic tract and some smaller tracts from the anterior lateral system, that means in the front but at the side, that passes up the anterior and the lateral columns of the spinal cord. So we're looking at this region here, the anterior and the lateral columns. Now it carries signals for pain, temperature, pressure, tickle, itch, and light and crude touch. Now the first order of neurons, which would be this here, the first order of neurons end in the posterior horn. There's a first order of neurons, and they're going to end in the posterior horn of the spinal cord. This is where they're going to synapse with the second order neurons that are going to decussate, which means they're going to cross over and form the ascending spinal thalamic tract, which proceeds contralaterally. In the thalamus, which is where we up here, in the thalamus, the third order neurons, they continue to the cerebral cortex. So here we have, this is the third order. Here's our thalamus area. So let me start here. This is our first order of neurons coming in and stopping at the posterior horn. They're going to synapse with the second order of neurons. They're going to deconsate and head upward towards the thalamus. They're going to synapse with the third order of neurons, which will take it the rest of the way to the cerebral cortex. Okay. Now, depending if it's going to be pain, if it's going to be pressure, the temperature is here, and we have pain on this side here, which is detected by different areas of the cerebral cortex. So in this diagram, this down here was dealing with temperature, but it was hot, it was too hot. Over here was dealing with pain. Someone got stuck with, it looks like a razor blade here. So it will enter in, this is our first order of neurons, entering through and stopping at the posterior horn. The second order of neurons will take it up to the thalamus, and then it'll go to the third order, synapse the third order neurons to this area in the brain that deals with pain. Now, our spinal reticular tract, it carries pain signals resulting from tissue injury. Now, the first order of, see if I have a diagram for that one. No, I don't, I'm sorry. Now, the first order sensory neurons, they're going to synapse with the second order of neurons in the posterior horn. So hopefully you guys remember where that is. We have another diagram, or have from the previous slide, and you have corner points. You can actually track it through with a pencil just to see exactly where it is or how it goes. Now they're going to decussate and ascend to the cord. That means they're going to cross over and then go up to the cord to a loosely organized core of gray matter called the reticular formation in the medulla and the pons. From there, they're going to have the third order of neurons that will continue from the pons to the thalamus. And of course, this one has a fourth order of neurons that will complete the path from the thalamus all the way up to the cerebral cortex. So for the reticular, we're going to have four orders of neurons. If I could find that track for you, the spinal reticular tract, I will definitely find it and post it online for you guys to actually see the tracks. And our last one is our last ascending tract is our spinal cerebral tract. Now the posterior and the anterior spinal cerebral tracts, they travel through the lateral column. Now they carry proprioceptive signals from the limbs and trunks to the cerebellum. Now the first order of neurons, they're going to originate in the muscles and tendons and end in the posterior horn of the spinal cord. They're going to synapse with the second order of neurons and send fibers up the spinal cerebellar tracts and end in the cerebellum. Now the fibers of that posterior tract, they're going to travel up the ipsilateral side of the spinal cord. So that's on the same side. They're not crossing. And then the fibers of the anterior tract, they're going to cross over. That means they're going to decussate and then travel up the contralateral side. So when we talk about contralateral, don't forget, contralateral means that they've crossed over and they've headed up. They had to decussate and then travel up. Ipsilateral means they haven't decussated, they just went straight up. So while the anterior side decussates, it crosses over and then travels up the contralateral side, but then it does not cross it. Then it crosses back in the brain stem. So it's going to decussate again, but in the brainstem, to enter the ipsilateral side of the cerebellum. So it's going to decussate twice with our spinal cerebral tracts. Okay, so here is, I do have a spinal cerebral pathway. So here's our first order of neurons, which is going to synapse with the second order in the posterior horn. It heads up, it decussates, and it's supposed to decussate again in the cerebellum. Alright, so let's take a look at the descending tracts. In the descending tracts, motor cells are carried from the brainstem in a pathway, typically including two neurons called the upper and lower motor neurons. Okay. Now the upper motor neurons, begins with a soma and a cerebral cortex, or the brain stem. Now the axon of the upper motor neurons, they're going to terminate on a lower motor neuron in the brain stem or a spinal cord. Okay. And then the axons of the lower motor neurons, let me pull everything up on this slide because I think that information is at the bottom so you guys can follow. There we go. Okay, so that the axon of the lower motor neuron then innervates the muscle or the other target organ. Now there are four ascending tracts. We have the cortical spinal, the texospinal, and the lateral and medial reticulospinal. Then we have the lateral and the medial vestibulospinal tracts. Now the commands are delivered by either somatic or autonomic nervous systems. The somatic nervous system, it directs contractions of the skeletal muscle, and the autonomic nervous system directs the activity of glands, smooth muscle, and the cardiac muscle. Let's take a look at some of the descending tracts. I did pull out some extra ones off the internet because there's more than just the ones that your book lists. But here's our corticospinal tract, and it's dealing with conscious control of the skeletal muscle. So everything on this side that I'm going to pull up are dealing with conscious motor control. Okay, and everything on the opposite side are dealing with subconscious motor control. Alright, so the ones that I have in blue, basically all of these are the ones that are listed in your textbook. Okay, you see that with the cortical, actually not the cortical, this one is not listed, neither is the, let me see the lateral, nope, the lateral cortical spinal, neither anterior cortical spinal, those are not listed. But we do have the cortical spinal tracts, which deal with the conscious control of muscles, and the lateral one and the anterior one, basically they deal with the same thing. The lateral and medial reticular spinal, that one's listed, and that is dealing with conscious motor control. And then we have the lateral and medial vestibular, vestibular spinal tract is also under subconscious motor control. Alright, so let's look at the cortical spinal tract. It carries motor signals from the cerebral cortex for precise, for precise, finely coordinated movements. Now the fibers form ridges called pyramids on the anterior surface of the medulla oblongata, and so were once called the pyramidal tracts. So they're once called pyramidal tracts. So here's my pyramids here. One here, over here. They look like baseball bats right next to each other. Now most of these fibers, they decussate in the lower medulla and form the lateral cortical spinal tract on the contralateral side of the spinal cord. Now a few fibers, they remain uncrossed and form the anterior cortical spinal tract on the ipsilateral side. However, these fibers have decussated lower and still control the contralateral side. So here's some more information. Branching off where you have the lateral and you have the anterior tracts of the cortical spinal. You have the upper neurons, which direct pathways in the cerebral cortex, and the lower neurons in the spinal cord. So here is an example, a nice diagram dealing with the cortical spinal pathway for laterally and anteriorly. And when we look at laterally, we see that the first motor neuron will come in anteriorly. Yeah, because this is, I'm sorry, it's descending, so I'm starting from the top. So, so in response to whatever happened in the skeletal muscles in the lower limbs, we're going to have a response from this part of the brain. This comes all the way down, and the signal passes through the midbrain, the outer motor neuron, comes all the way down, passes through the pons, everything through the anterior view, and then it's going to decussate at the pyramid. When it reaches the pyramid in the pons, it's going to cross, decussate, and come down, picking up the lateral cortical spinal tract, then hitting the lateral column of the white matter, synapsing with the third neuron and exiting out, or the second neuron, and exiting out the anterior spinal root. And similarly with the anterior, same pathway down, but it does not decussate. Comes straight down, past into the pyramid, still in the anterior cortical, or the anterior column, or the anterior tract, down, and then it will decussate and synapse with that last neuron, the lower motor neuron, and exiting out through the anterior spinal tract. Sorry, the anterior spinal cord. Spinal root. Oh my word, sorry, anterior spinal root. So here are the rest of the descendant tracts. The tectospinal tract, it begins in the midbrain, which is tectum, and it crosses to contralateral sides of the midbrain. So when it comes down, it crosses the contralateral side of the midbrain. It sends information to the head, neck, and upper limbs and responses to bright and sudden movements, and of course loud noises. Now the tectum area consists of a superior and inferior colliculi. Now the superior colliculi, it receives visual information, and the inferior colliculi, it receives auditory information. Now lateral and medial reticulospinal tracts, they originate in the reticular formation of the brain stem and the control muscles of upper and lower limbs, especially those for posture and balance. Now they contain descending analgesic pathways in which they're going to reduce the transmission of pain signals to the brain. Now our lateral and our medial vestibular tracts, they begin in the brainstem vestibular nuclei. It receives impulses for balance from the inner ear, and it controls extensor muscles of limbs for balance control. That's the same thing on that slide. I will delete that. Alright, so here we're going to look at the spinal nerves and look at the anatomy of the spinal nerves. Get a better understanding of what's going on with just the general structure of the nerves and the ganglia. So the nerve is a cord-like organ composed of numerous nerve fibers called axons, and they're bound together by connective tissue. A nerve may consist of a few nerve fibers or hundreds of thousands. The nerve fibers of the PNS are in sheath with swan cells that form a neurolema, and often a myelin sheath around the axon. So we here have some that are myelinated and others that are not myelinated. Now, external to the neurilium, each fiber is surrounded by a basal lamina and then a sleeve of loose connective tissue called the endurium. the endoneurium. Come on, here's our endoneurium, which is this bluish colored structure here you see in the diagram. This is your endoneurium, and these are the myelinated fibers, which you see that whitish structure here, the whitish structure here we have around the orange structures. This is your myelin nerve fibers, but then this is the myelin sheath, swan cells that are surrounding it. Okay, and this one is unmyelinated. It's not encapsulated by any myelin. Okay. Now the nerve fibers, they're gathered into bundles called fascicles, well, each wrapped in a multi-layered sheath called the pericardium. So here's our pericardium. So each fascicle, these are fascicles here, they're enclosed by the pericardium. So here are nerve fibers. So a bundle of nerve fibers are considered to be fascicles. So that's 1, 2, 3, 4, 5, 6, 7, 8 that we have in this one. Now these fascicles are wrapped in the perineurium, and they're going to contain, which contains up to 20 layers of squamous epithelium, which are like cells. Now several fascicles are then bundled together in an outer epineurium. So once these fascicles are put together, they're all going to be surrounded by another layer, and that is the outer layer called the epineurium. The epineurium is composed of dense, irregular connective tissue, and it protects the nerve from stretching and injury. Now, nerves have a high metabolic rate and they need plenty of blood supply. So you see the blood vessels strategically positioned so that the blood can reach these particular nerve fibers. So they're going to have a number of blood vessels that are going to penetrate the connective tissue surroundings. So here's more of the information pertaining to what I was just talking about. Now we do have mixed nerves. Mixed nerves, they're going to contain both sensory and motor fibers. I'll just pull up all this here for you guys. So don't forget, you're going to have to save it on your flash drive. You can print it out with 6 slides per sheet to follow along. Okay, so we have poliomyelitis and ALS. ALS stands for let me see if I can get this right. Amyotrophic lateral sclerosis. And both diseases, they cause destruction of motor neurons and production of skeletal muscle atrophy from lack of innervation. So with poliomyelitis, now poliomyelitis is caused by a poliovirus. It destroys the motor neurons in the brainstem and the anterior horn of the spinal cord. Now, signs of polio includes muscle pain, weakness, and loss of some reflexes, and is followed by paralysis, muscular atrophy, and respiratory arrest. Now, the virus spreads by fecal contamination of water. So if you have an infected cattle or cattle, and it gets into the water, of course, unknowingly you'll consume it, and it will go through our digestive tract, and it will start to replicate even before it even gets to the intestines. So it's going to replicate in our pharynx, and of course get to our GI tract and continue to replicate. Then after it replicates in the GI tract, it's going to spread to the lymphatic system through the blood, and of course to the CNS, the central nervous system. And when it's in the central nervous system, it's going to begin to destroy or damage a lot of the nerve fibers, and eventually destroy the motor neurons. Now, ALS is also destruction of the motor neurons and causes muscular atrophy very rapidly. Also, sclerosis, which is scarring of the lateral regions of the spinal cord, will also occur. We have astrocytes. They fail to reabsorb the neurotransmitter glutamate from the tissue fluid. So once that's not picked up or reabsorbed, that glutamate is going to be kept in the tissue and cause high levels of toxicity. Now that is going to cause muscular weakness, difficulty to speak, swallowing, difficulty using their hands and breathing with ventilate, and they'll have to start breathing with a ventilator. Now, within 3 to 5 years of onset of the disease, some people die of respiratory failure. Now, there's only a small percentage that will survive after 10 years of being diagnosed. Now, of course, the sensory and the intellectual functions remain unaffected. So you see the wasted or the atrophic muscle, and here we have the nerve fiber, the neuron that is affected by the disease. Now the PNS, the peripheral nervous system, nerve fibers, are of two kinds. We have sensory fibers and motor nerve fibers. Both can be classified as somatic or visceral, and as either special or generic. Or general. Now nerves can be classified as either sensory, motor, or they can be classified as mixed. Now sensory nerves, they're composed only of afferent fibers and are rare and include olfactory and optic nerves. The motor nerves, they carry only efferent fibers. And most nerves are mixed nerves consisting of both afferent and efferent neurons, fibers that each conduct signals only one way. Well, in two ways, sorry. And both sensory and motor neurons can also be described as somatic, and of course are general and visceral. Now we're looking at the ganglia. This is where the ganglion is located on the posterior spinal root. Here's our spinal cord. Here is our posterior spinal root, and here is our anterior spinal root. On the posterior spinal root is where we're going to find the ganglion. It is on this side, the posterior root ganglion. So remember, always the posterior ganglion root is on the posterior spinal nerve. It's a cluster of neurosomas outside of the CNS. A ganglion is enveloped in an epineuron continuous with that of the nerve. Now, among the neurosomas are bundles of nerve fibers leading into and out of the neuron. So here we have neurofibers that are taken in the sensory information. And here we have a set of neurofibers taking motor information out. So therefore, we'll have sensory neurofibers and we have motor neural fibers. Now there are 31 pairs of spinal cords. We have 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Okay. Just to touch a little bit on the first cervical spinal nerves. Those are the ones that are going to merge between the skull and the axis, which is C1. Now the numbering of the spinal nerve corresponds to the number of the vertebra inferior to them. So those are the ones that are going to be underneath them. So nerve C5 merges above vertebrae 6. Now below the cervical vertebrae, the pattern changes. the remaining spinal nerves, they're going to merge inferior, that's under the corresponding numbered vertebrae, whereas we'll have nerve lumbar 3 will emerge inferior or under vertebrae L3. Now, the proximal branches of each spinal nerve occurs as it passes through the intervertebral foramina. Now, each spinal nerve arises in 2 points of attachment to the spinal cord. We have the posterior and we have the anterior. We have 6 to 8 rootlets. These are our rootlets right here. We have approximately 6 to 8 rootlets that emerge from the anterior surface and merge to form the anterior root of the spinal cord. So we have about 8 or 6 here of these spinal rootlets. Then we have another 8 or 6 rootlets that emerge, 6 to 8 rootlets that emerge from the posterior surface and merge to form the posterior root. To form the posterior root. Now then, on a short distance away from that, we'll form the posterior root ganglion. Now, distal from the ganglion, the anterior and the posterior roots, they start to merge. This is where they're going to merge. Okay? They're going to leave the dorsal sheath and form the spinal nerve properly. Now, the nerve then exits the vertebral canal along the vertebral canal through the intervertebral foramina. Nerve is considered to be a mixed nerve. So right here will be our mixed nerve. Here will be our sensory nerve, and here is our motor nerve. Now, the anterior and the posterior roots are shortest in the cervical region and become longer inferiorly. The roots of segments L2 to the coccygeal of the cord, they form an adult equina. Now, some viruses invade the CNS through these particular roots. So here we get a better view of the spinal nerves. And what I mentioned earlier pertaining to where the cervical nerve will innervate or will emerge, it's way up here. So here we have the various nerves. We have C1, C2, C3, C4. And when I mentioned that the first cervical spinal nerve will merge between the skull and the atlas, here's our C1. There's the skull and our cervical axis. So here is our vertebral C1, and here's our C1 nerve, and our C2 nerve, and we have our vertebrae 2, vertebrae 3, and vertebrae 4. So that's 1, 2, 3, and 4. So with that, you see that this is 1, 2. This is our vertebra C2, and we have our spinal nerve C2. So it's 1, 2, 3, 4, 5. So notice that the nerves are gonna emerge, inferior to the bone. So this This is the atlas, and that's the skull. But this is supposed to be C1, 2, 3, 1, 2, 3, 4, and 5. Not that one. So it's inferior. Inferior means underneath. So disregard what I just said. This is showing vertebrae C1, when actually this is like C1, 2, 3, 4, 5, because inferior means underneath. So C1, yeah, that's correct, I'm sorry. So here's the skull, and here is your C1. So C1 is going to innervate between there. Then we go C2, C3, C4, and C5. So when we get to C5, it starts to change, but the numbering is going to correspond with the number of the vertebrae inferior to them. So now we're going to continue and have then from C5 we have, this is 1, 2, 3, 4, 5 vertebrae. 1, 2, 3, 4, 5 vertebrae. And our cervical, our C5 is supposed to be inferior to it. And here we have the various spinal nerves. We have our C8, we have an 8 cervical, we have our 12 thoracic, we have our 5 lumbar, and our 5 sacral, and our 1 coccygeal. Sorry, our 1 coccygeal nerve. 1 pair of coccygeal nerves, which is right here, 1. Okay. Now the distal branches of the spinal nerve are more complex. Now immediately after emerging from the intervertebral foramen, the nerve divides into an anterior ramus, a posterior ramus, and a meningeal branch. Now each spinal nerve branches on both ends, anterior and posterior roots. They approach the spinal cord, and the anterior and the posterior rami then lead away from the vertebral column. When we look at the meningeal branch, it re-enters the vertebral column and innervates the membranes, vertebrae, and the spinal ligaments. Posterior ramus, it innervates the muscles and the joints in the region of the spine and the skin of the back. The anterior ramus, innervates the anterior and lateral skin and muscles of the back and gives rise to the nerves of the limbs. Now the anterior rami vary from one region to another. In the thoracic region, it forms an intercostal nerve, and in all other regions forms the nerve plexus. The anterior ramus also gives off a pair of communicating rami that connect with a string of sympathetic chain ganglia and spinal nerves T1 through L2. So here's our diagram. Here's anterior ramus. There's our posterior ramus. And then our communicating rami. Communicating rami. And we have our meningeal branch. Communicating rami, which we'll get into that. There's another view. I thought this was pretty neat, where you see your arachnoid matter, which we talked about earlier on in this chapter. We have our dura mater. We have our rootlets. So we have 1, 2, 3, 4, 5, 6 rootlets. You see the blood vessels. I think this is so neat. You can see the blood vessels in here supplying the spinal nerve. And we have our posterior root. And we have our posterior ganglion right in here. And then we have our anterior root. And we talked about the ascending tract, aggressive fasciculus, which is right in here. Okay. And there's our lateral column. And in there. Now, except in the thoracic region, the anterior rami branch and merge to form 5 web-like nerve plexuses. We have the cervical plex, brachial plex, lumbar, sacral, and coccygeal. Now, the spinal nerve roots, they give rise to each plexus and may also include smaller branches called trunks, anterior divisions, posterior divisions, and cords. When look at this cervical plexus is found in the neck, and it's from C1 to C5, and it supplies the neck and the phrenic nerve to the diaphragm. The brachial plexus, it's near the shoulder, and it supplies C5 to T1, and supplies to the upper limb and some of the shoulder and the neck. The lumbar will be in the lower back, and it's from L1 to L4, and it supplies the abdominal wall, the anterior thigh, and the genitalia. The sacral plexus is in the pelvis. We have L4, L5, and S1 to S4, and it supplies the remaining lower trunk and the lower limb. The coccygeal plexus, S4, S5, and the coccygeal is formed by the 5th sacral nerve with a contribution from S4 and the coccygeal nerve, and it gives rise to the anococcygeal nerve. So here you have a cross section, another diagram of what everything looks like and how these nerves start to radiate and disperse to their current destination. Here we have the spinal nerve. Here's our vertebrae. And the spinal nerve right in between, spinal cord in between, and the branching off of the spinal cord. You have the communicating rami. We have the anterior and the posterior. Come on. The anterior and our posterior ramus. And we have the intercostal nerve. So it's very obvious what that is going to supply. And over here you get a better view of exactly what it looks like. Side and anterior lateral view with our spinal cord here and our vertebrae, and how everything is situated between the spinal cord, where the different layers are dural matter, arachnoid matter, and our pia matter, and then our spinal cord with the posterior and anterior roots and our posterior ganglion. To continue with the nerve plexus, they have 2 functions. They have a somatosensory function and a motor function. The somatosensory function, they're going to carry the sensory signals from the bones, the bones, joints, muscles, and skin to the CNS. And we have motor function that's primarily to stimulate the muscle contraction. The proprioception, that deals with that's when the brain receives information about body position and movements from nerve endings in the muscles, tendons, and the joints. Now let's take a look at chickenpox. Most people have had chickenpox, and it's a disease that occurs early in childhood, and it's caused by this varicella zoster virus. It produces an itchy rash that clears up without complications. It causes these red spots or blisters all over the body. Now the virus remains for life in the posterior root ganglia, okay, and is kept in check by the immune system. And as the virus becomes active again, it will lead to shingles. Now, shingles is been on an uprise the last couple of years, last maybe 10 years, I should say. And it's a herpes zoster, and it's localized disease because by the virus traveling down the sensory nerves by fast axonal transport when the immune system is compromised. It's common after the age of 50, but nowadays a lot of people are getting it earlier, like in their 40s, mid 40s, some in their 30s as well. And it's a painful trail of skin discoloration and fluid-filled vesicles along the path of the nerve. It's usually in the chest, waist, on one side of the body. It's this person suffers from pain, itchiness, you have a burning sensation, you have numbing and tingling. And some people may get fevers and chills, headaches and fatigue. Now, childhood chickenpox vaccinations reduce the risk of shingles later in life. So hopefully everybody has gotten their childhood vaccinations for chickenpox. Alright, so let's take a closer look at the cervical plexus, just to see exactly where it is going to be originating and where it's coming out. I believe these diagrams are in your textbook as well. So the purple color here, notices or shows that this is indicating the root. It should be located in those areas right here that you cannot see. Then they start to branch off. Okay. Alright, so this diagram can be found on page 495. Okay. I gave you the functions of where, well, the final destination of these particular nerves. But you see they start to branch off. And we have the lesser, let me see first. Sorry, we have the phrenic nerve, we have the supraclavicular nerve, and we have about 4 other nerves that are going to branch off just from the rootlets, or just from the roots of these cervical nerves. And everybody having a very different destination, well, an innervation. Now the lesser occipital and the greater auricular, the transverse cervical nerve, they don't have any muscular innervations, but the remaining, oh, and also the supraventricular nerve, they don't have an innervation, but the ansa cervicalis, that one's going to innervate with the sternothyroid muscles, and the phrenic nerve, that's going to innervate with the diaphragm. Let's head on to the other one on page 496, the brachial nerve. Here we have the roots, we have the trunks in the red, we have the anterior division in the green, and the posterior division in the blue, and the cords, I don't think you guys can see down here, but the cords will be in this brownish or tan color. Now from the brachial plexus, we have a number of nerves that are going to come off of that. We have the ulnar nerve, the median nerve, the radial nerve, the axillary nerve, and the musculocutaneous nerve. So see how they branch off and they form into the various nerves, the 5 nerves that I mentioned here. And of course, you're going to have muscle innervation with the biceps, the deltoids, the forearm, as well as the adductor muscles. This is our brachial plexus, our lumbar plexus on page 498. They also have a number of nerves. Here we have them here that are going to that are the divisions of the lumbar plexus. And these nerves have various innervations, either the quadricep, the serratus muscle, the thigh muscle, the medium adductor, the internal external obliques, and the abdominal obliques, and the transverse obliques. Here's our sacral and our coccygeal nerves. Here's our coccygeal, don't forget it, is from L4 to S5, and then we just have one pair of coccygeal nerves here. Yeah, okay. And then we have a number of other nerves that are going to branch off of these plexuses. And these nerves are obviously going to supply the gluteus maximus, the medius, the hamstrings, the bicep femoris, which is one of the muscles in the hamstrings, the anterior and lateral muscles of the leg, the anterior digatorium brevis, which is the muscles of the foot. Alright, so let's look at some nerve injuries. We have the radial nerve injury, and that passes through the axilla, and it controls the tricep movements, extending the wrist and the fingers, and controls the sensation in a portion of the hand. If a person has this type of injury, they'll have crutch paralysis, they'll have a wrist drop, and sleeping in the upper arm in an upward position. So those are some things that can cause injury to the nerve. Because usually if you hold your hand in a particular position for a while, you know that when you stretch it out, it feels a little numb. You just not really pinched it, we just squeezed the radial nerve, stopping sensation to that part of the body. Also, falling on or receiving a blow to the arm can cause damage or harm, injury to the radial nerve, and long-term constriction of the wrist, such as in a tight bracelet or in a tight bandage. Then we have a sciatic nerve injury. Sciatica is a sharp pain that travels from the gluteal region along the posterior side of the thigh and leg to the ankle. You'll have weakness, numbness, or tingling in the leg. Now, 90% of cases result from herniated intervertebral disc or osteoporosis of the lower spine. Some would be slip disc, spinal stenosis, tumors, pelvic injury, or fracture. Now, each spinal nerve, except C1, receives sensory input from a specific skin area called the dermatome. Now, dermatomes may overlap at their edges by as much as 50%. Now, there's three necessary spinal nerves. Three successive spinal nerves must be anesthetized or served to produce a total loss of sensation from one of those dermatome. And here we have a dermatome map, which is a diagram of the cutaneous regions innervated by each of the spinal nerves. So here's our C2. Remember, there's nothing for C1, but C2 is basically in our lower jaw on the other side. Here's a region for C3 in our upper neck, Our C4 is lower neck and part of the shoulder. And C5 is basically the remaining part of the shoulder, the clavicle all the way down. I think it's pretty neat. Then we have our T1. Then we have our T2, 3, 4th, and so on. Now, reflexes are quick, involuntary, stereotype reactions of glands or muscles to stimulation. Automatic reflexes to sensory input that occur without our intent or often even with our awareness. Now, there are 4 characteristics of reflexes. Reflexes, they require stimulation. They are quick, involuntary, and they're stereotyped. When it comes to stimulation, they are responses to sensory input. Quick reflexes, they involve few, if any, interneurons and minimal synaptic delay. Involuntary, they occur without intent and often without awareness. And stereotyped, they occur the same way every time. Now, reflexes include glandular secretions and contractions of all 3 types of muscles. Now, they include some learned responses, which are conditioned reflexes. Now, some reflexes are unlearned skeletal muscle reflexes mediated by the brain stem and the spinal cord that involve the somatic nervous system. Now, a somatic reflex, it employs a reflex arc that involves the following pathway. We have the somatic receptors in the skin, muscle, or a tendon. Then we have the afferent nerve fibers. And they carry information from the receptors to the posterior horn of the spinal cord or the brainstem. We have our integrating center, which is in the gray matter of the spinal cord or the brainstem, consisting of 1 or more neurons. And it determines whether efferent neurons issue signals to the muscles. Then our efferent nerve fibers, they're going to carry the motor impulses from the CNS to the skeletal muscles. Then we have our effectors. And they are the somatic effectors that carry out the response. So yes, the information can be carried to the muscle, but if these effectors aren't working, you're not going to have the response to actually move. So many somatic reflexes involve stretch receptors called muscle spindles. Muscle spindles are among the body's proprioceptors. They inform the brain of muscle length and body movements. They are especially abundant in muscles that require fine control, such as the hands and the fingers. Now, muscle fibers are named for their infused shape. They are scattered throughout the perimysium of the muscle with their long axis parallel to the fibers. So here's a small diagram of the muscle spindle, and then we enlarged it here, and you see that they have their shape is a fusiform shape, and they have these concentrated ends near the tendons. Now the spindles, they contain approximately 2 to 12 modified muscle fibers and a few nerve fibers wrapped in a fibrous capsule. The muscle fibers within the spindle are called intrafusial fibers. Or intrafusial fibers. while those that are wrapped, but those that make up the rest of the muscle are called extrafusal fibers. So here's our extrafusal fibers, and here are intrafusal fibers. Let me pull this up for you guys. Now the intrafusal fibers are modified muscle fibers that have contractile ability only at two ends. There are two classes of fibers. We have the nuclear chain fibers with a single file of nuclei in the non-contractile region. They are typically 5 in a spindle. Now the nuclear bag fibers with nuclei clustered in the bag-like middle region. They are typically 2 or 3 in a spindle. The muscle fibers, the muscle spindles have three principal classes of nerve fibers, 2 sensory classes and 1 motor class. We have the primary afferent, group A, fiber that arises from the annulospiral endings. It is large and is the fast nerve. Now there's up to 8 secondary afferent, group 2 fibers that wind primarily around the nuclear chain fibers adjusted to the annulospiral endings, and they are intermediate sized fibers. Now the gamma motor neurons, they originate in the anterior horn of the spinal cord, and they lead to the contractile ends of the intrafusal fibers. These serve to adjust the sensitivity of the muscle spindle. Alright, so when a muscle is stretched, it contracts to compensate, an action called stretch or myostatic reflex. So when a muscle is stretched, it fights back and contracts, maintaining increased tonus and making it stiffer than the unstretched muscle. Now it helps maintain equilibrium and posture. Just like a head stunted to tip forward as you fall asleep, muscles contract to raise the head. So you're going to have synergistic and antagonistic feedback. Now stretch reflexes smooth out movements and are important for coordinating vigorous and precise movements. A stretch reflex is mediated primarily by the brain and is not strictly a spinal reflex, but a component of it is spinal and can be more pronounced to very sudden stretches. An example of a tendon, now if we look at the tendon reflex, it's a reflex contraction of the muscle when it is when its tendon is tapped. And that's an example of a knee-jerk reflex. Whoever those have been to the doctor, they understand when this is the type of procedure that they would do just to see what type of reflexes that you have when they tap your knee. It's called a knee-jerk procedure. Now testing somatic reflexes, it helps diagnose many diseases, such as Achilles reflex, bicep reflex, patellar reflex, also gag reflex. We have reciprocal inhibition, which is a reflex phenomenon that prevents muscles from working against each other by inhibiting the antagonistic. So here we have the patella tendon reflex. What happens here, the patella is tapped. The patella tendon, which is the posterior, no, not the posterior, I'm sorry, the inferior part of the tendon is tapped, which is basically under the kneecap or the patella. And with that tap, it starts to excite these particular nerve endings. of the muscle spindle in the quadricep. This information, the sensory information, is sent inward through the posterior, through the spinal cord, spinal nerve, to the spinal, to the posterior ganglion root, to the posterior spinal cord, into the posterior horn. Now, when the information gets there, it's not working. We have a primary afferent neuron that's going to stimulate the alpha neuron in the spinal cord. The efferent signals in the alpha motor nerve fiber, they're going to stimulate the quadricep to contract, producing that knee jerk. Now, at that same time, a branch of efferent nerve fibers, they're going to stimulate the inhibitory motor neuron in the spinal cord. And that neuron will inhibit the alpha motor neurons that supplies the quadricep muscle. Therefore, the hamstring muscles. Therefore, the hamstring contraction is inhibited. So they're going to relax. So you can't have both the quadricep muscle and the hamstring contracting at the same time. One has to contract, which is your quadricep, and the other one is going to be relaxed. Now, with our flexor and cross extension reflexes, the flexor reflex, that is a quick contraction of the flexor muscles resulting in a withdrawal of a limb from an injurious stimuli. So if you're stepping on a glass, like you see here in the diagram, you're going to have a withdrawal of the leg. So it's going to involve a more complex neural pathways. It involves contraction of the flexors and relaxation of the extensors in the limb. Sustained contraction is produced by a parallel after discharge circuit that is part of the polysynaptic reflex arc, which is a pathway with many synapses. Now, some signals will reach the muscles quicker and others a little bit later, and that's providing prolonged output from the spinal cord. So what's happening here? What do you think is happening here? Here we have an individual stepping on a glass within the water. When he steps on the glass, the receptors in the bottom of the foot are going to be send the information to the sensory neuron into the spinal cord. While in the spinal cord, in that gray matter, it's going to activate a lot of the neurotransmitters, the interneurons. You have some that are going to decussate over to the opposite side, but let's deal with those on this side first. So we have multiple neurons that are going to be activated. When they're activated, it's going to send out a motor response to the quadricep by the ipsilateral neuron. So remember, it's on the same side, it's not crossing over. And those motor neurons are going to activate or excite these reflexor muscles. The ipsilateral reflex will contract. So we're looking at both the quadricep contracting, the flexor muscles contracting, causing you to raise your foot off the glass. At the same time, you're going to have the other set of interneurons. Some are going to decussate over to the opposite side, which is our contralateral motor neurons. They're going to excite the extensors. So that's in the opposite foot, the foot that was the planted foot. Causing your contralateral extensors to contract. So here's your cross-extensor reflex. That's a contraction of the extensor muscles in a limb, opposite of the one that is withdrawn. It also is activated by the interneurons. It maintains balance by extending the other leg. So to make sure that you do not fall over, this contralateral motor neurons have to activate these particular these muscles here to make sure that you don't fall over. Because don't forget, when you're walking, you're placing the right foot on the ground, not knowing that there's a broken bottle on the floor or a pin on the ground. So that weight is going to be transferred from left to right, from left to the right foot. So when that weight is being placed down on that right foot and realize that you're stepping on a glass, you have to try and get that weight transferred back to that left foot so that you do not fall over. And that's where that second integration, where the decompensation occurs, just to make sure that you don't fall. That's our contralateral reflex arc. Okay? So just to go over, our ipsilateral reflex arc, one in which the sensory input and the motor input are on the same side of same sides of the spinal cord. And our contralateral is one in which input and output are on the opposite sides. So it came in from the right side, but for the contralateral, it crossed or decussate to the opposite side of the spinal cord for the reaction to occur. So that's our cross-extension reflex. Our intersegmental reflex is one in which the input and the output occur at different levels of the spinal cord. So let's look at our tendon organs. Remember, tendons are what connect muscle to bone. We have proprioceptors in the tendon near its junction with a muscle. They have a ganglion tendon organ, which is 1 millimeter long, and the nerve fibers that intertwine in collagen fibers of the tendon. Tendon reflex, in response to excessive tension on the tendon, it inhibits muscles from contracting strongly, and it modifies muscle contraction before it tears the tendon or pulls it loose from the muscle or the bone. So here we have some trauma. You have spinal cord trauma. Spinal cord trauma is basically damage to the spinal cord. Now, in the United States, there's about 10,000 to 12,000 people that are paralyzed each year by spinal cord trauma, usually by vertebral fractures. The highest risk group, males 16 to 30 years old. Now, 55% occur in automotive or motorcycle accidents. Now, complete transection. This is a complete severance of the cord. There's a complete severing. Now, you have immediate loss of motor control below the level of injury. Now, above C4, it poses a threat of respiratory failure. You also have spinal shock, which is spinal shock. With spinal shock, this is when a spinal cord injury is caused due to trauma, and the body doesn't goes into a state known as spinal shock. Now, when the spinal shock begins within a few minutes of the injury, it may take several hours before the full effects occur. Now, during spinal shock, the nervous system is unable to transmit signals, some of which may return once the spinal shock has subsided. The time the spinal shock lasts is approximately 4 to 6 weeks following an injury, and it affects movement, sensation, and how well the body systems will function. Here we have paralysis. Paralysis is a loss of muscle function in part of the body. We have sensation, sensory loss. If the sensory or motor divisions are damaged. Paraplegia. Now, paralysis is basically a general term. I wanted to bring that in. It's just a general term to describe the loss of movements or sensations following damage to the nervous system. Now, knowing the precise level of the injury is helpful in predicting which parts of the body would be affected by paralysis or loss of the functions. So we have paraplegia. That is paralysis of both the lower limbs and possibly the trunk. Quadriplegic or tetraplegia. That is paralysis of 4 limbs. The hemiplegia, that's paralysis of just one side of the body, which we do not see in this particular diagram, one side of the body. And paresis is partial paralysis or weakness of a limb. If you guys have any questions, I know it was pretty long, it was like approximately 67 slides or so, but if you guys have any questions, don't forget you need to post those questions in the discussion board under chapter 13.